अभिव्यक्त करने के लिए शब्दों का सहारा लेना पड़ता है। भावनाओं को अभिव्यक्त करने के लिए शब्दों का सहारा लेना पड़ता है। शब्द कम पड़ जाते हैं कभी-कभी। ऐसे में आंखें संभाल लेती हैं सब कुछ। शर्मा सर के लिए ऐसे में आंखें संभाल लेती हैं सब कुछ। आंखें भावनाओं को अभिव्यक्त करने का जरिया बन जाती हैं। सर पूछो तो वे हमराज बनकर बहुत कुछ कह जाती हैं। थैंक यू।
सर्वे भवन्तु सुखिनः,
सर्वे सन्तु निरामया,
सर्वे सन्तु निरामया,
सर्वे भद्राणि पश्यन्तु,
सर्वे भद्राणि पश्यन्तु,
मा कश्चित् दुःखभाग्
भवेत्,
न त्वहं कामे राज्यं,
न त्वहं कामे राज्यं,
न स्वर्गं न पुनर्भवम्,
न स्वर्गं न पुनर्भवम्,
कामे दुःखताप्तानां,
कामे दुःखताप्तानां,
प्राणिनां आर्तिनाशनम्।
प्राणिनां आर्तिनाशनम्।
थैंक यू। प्लीज।
Thank you GP Association for giving me this opportunity to present in front of all of you, in front of all the stars from their own field. Thank you so much ma'am and sir, and thank you Sharma sir at the last moment, a big support. If you are here, I feel that I'm in class and presentation is going on and you are there to manage everything. Thank you everyone. When I was asked to present something on eye disease, so I talked about diabetic retinopathy with ma'am. And I chosen the topic, I am not guilty. Ma'am was not very impressed with the topic. But the reason of picking up this topic is that everything which happens in the eye, that is not responsible at all. शरीर में दर्द होता है, आंखें रोती हैं. दिल में दर्द होता है, आंखें रोती हैं. आंखों का क्या दोष? तो उसी तरह से whatever happens in our eyes, we are responsible. And everything comes in front of the retina or inside our eyes. So this was the topic which I picked up. I am Dr. Kirti Agarwal, retina specialist from Mittal Eye Hospital, Betihata, Gorakhpur. So I would like to tell, there is one saying that eyes are said to be poets to the windows. I picked up this poem for a magazine which we print every 6 months for the awareness of patients. So the eyes are said by poets to be the windows to the soul, but for we physicians, they are also windows to the brain. Examining the retina gives a good idea of the state of brain as it directly connected to it. Apart from the brain, it gives the idea about whatever happening in our heart, kidney as well. So according to the recent epidemiology, which I went through last day only, as per Indian Council of Medical Research, India Diabetes study published in August 2023, the prevalence of diabetes is 10.1 crore in India, which is quite high and slowly it is increasing. Every 5 seconds a person is diagnosed with diabetes and every 10 seconds someone dies of it. And every 30 seconds a limb is lost due to it. You people know better than us. And diabetes affects the blood vessels and nerves and therefore can affect any part of the body. And as I discussed, it mainly affects kidney, heart, foot and eye. So eye problems related to diabetes, if we start from anterior to posterior, because they are prone to infections. So lid infections are very common. Whatever happens, slightly itching or touching to the eye, they catch the infection very soon. Then fluctuating of the vision due to lenticular changes. Whenever there is increase in the blood sugar, there is edema in the lens which causes the myopic shift. So patient is having fluctuating vision even with, and they complain of the frequent, whenever they go for the glasses to the general optometrist, the frequent glass changes are there. That might be because of their diabetes fluctuation. And because of this fluctuation, the lenticular changes happens early and cataract develops in the diabetes patient earlier than the normal patients. And last but not the least, the diabetic retinopathy, not the least because this is something which patient doesn't know. They don't know what is happening behind. After 20 years of diabetes, nearly 99% of the patient with type 1 and 60% patient of the type 2 diabetes have some degree of diabetic retinopathy, even if they are on well-controlled diabetes. 33% of the patient with diabetes have signs of diabetic retinopathy. And people with diabetes are 25 times more likely to become blind in comparison to the general population because of the diabetic retinopathy. So coming to the symptoms which patient comes to us, blurred vision. In vision, what they can complain that vision is wavy, whatever they are seeing is, they can see, they can read, but the images are either wavy, or they are seeing, but wherever they are seeing, they are not able to see there, where they are focusing, they are seeing apart from it, or they are able to see, but something is floating in front of eye. So, blurred vision, floaters, what I said, fluctuating vision, as I discussed with the diabetic fluctuations, distorted vision, dark areas of vision, wherever the ischemia is there, that part causes darkness. Poor night vision and impaired color vision because of the involvement of macula, and partial or total loss of vision. Thank you. So, the main pathology which happens in all over the body, but which shows in eye, is that microangiopathy or microvasculopathy, that causes the retinal capillary occlusion as well as the retinal capillary leakage. Retinal capillary occlusion is because of the atherosclerotic changes, and the leakage is because there is weakening of the capillary vessels. So, the microvascular occlusion is caused by thickening of the capillary basement membranes, abnormal proliferation of the capillary endothelium, increased platelet adhesion, and increased blood viscosity and defective fibrinolysis. So, in diabetic retinopathy, whatever we give the antilipid, that also helps. So, coming to the chart, we can understand better that in microvascular, this microvascular occlusion causes ischemia. Ischemia will lead to the increased vascular endothelial growth factor in the vitreous and the retina. This vascular endothelial growth factor causes neovascularization near the disc or the retina, and this neovascularization further, if not treated, can lead to fibrovascular bands, and fibrovascular bands causes tractional retinal detachment. This is the worst part of the diabetic retinopathy. If this ischemia leads to infarction, the infarcted part will show as a cotton wool spot on the retina. This is the alarming sign that we should go ahead to stop the diabetic retinopathy progression, and if this infarction is not stopped, then it may lead to neovascular glaucoma, which is another vision threatening condition. And if neovascularization is not controlled, and if it is not so deteriorated to form the fibrovascular band, it may cause vitreous hemorrhage, which causes sudden diminution of vision. Though it sounds scary that there is sudden diminution of vision, but if the patient has developed neovascularization and sudden defective vision because of vitreous hemorrhage, it is kind of alarming symptom, because the moment there will be sudden diminution, they will go to the doctor. Once the vitreous hemorrhage is subsided, we can see and we can control the diabetic retinopathy. So, rather it is safe than leading to the fibrovascular band formation and retinal detachment and then neovascular glaucoma. So, microvascular leakage is caused by impaired, it's somewhat correlated everything, impairment of the endothelial tight junctions, loss of pericytes, weakening of capillary vessels, and elevated levels of vascular endothelial growth factor. I will come to it that why this VEGF I am discussing again and again. So, recommended eye examination, this is an important slide for all of us. Type 1 diabetes gets the diabetic retinopathy earlier than type 2. So, type 1 diabetes 3 to 5 years after diagnosis, the examination should be done, and in both the cases, type 1 and type 2, the routine follow-up should be done yearly, and in type 2 at the time of diagnosis. If the patient is diabetic and planning to conceive, then prior to the conception, the retina examination, dilate retina examination should be done. And as per finding in diabetes, in pregnancy with diabetes, we plan for the as per finding. If the patient is having mild diabetes, then we call her 2 or 3 times, and that too depends upon that how much control she is having during the pregnancy. So, this is the classification for diabetic retinopathy. I will not read, I will just say directly. We can, according to the ETDRS, we can classify the diabetic retinopathy in 2 stages. First is non-proliferative and second is proliferative diabetic retinopathy. We are firstly divided in 2 parts, because proliferative diabetic retinopathy, we need the treatment immediately, and in non-proliferative diabetic retinopathy, the treatment depends on the severity, whether it is mild, moderate or severe. the severe goes towards the proliferative very soon. Now I come to it. Whenever we see the patients, if there is if there is microaneurysm only, microaneurysm, very small hemorrhages, not exactly hemorrhages, the vessels, the endothelium which is already weakened, from there one outpouching will come out which causes microaneurysm, though that part is weakened, but this is reversible. Mild non-proliferative diabetic retinopathy, if we control at that moment, it is reversible. When we come to moderate, we can get soft exudate. We can soft exudate. I'll recall that thing, that there is ischemia or infarction of that particular area and microaneurysm, but more than the mild one. And then comes severe. In severe, there is 4:2:1 rule. We'll get the intraretinal hemorrhages in all the 4 quadrants. We'll get the venous bleeding in 2 or more. And then one change is there, intraretinal microaneurysm. I'll come to it with a picture in any 1 quadrant. This is the sign when it cannot be reversed, but it can be controlled. We can prevent the patient from deteriorating the vision. This is no retinopathy. Optic nerve is fine, macula is fine, right eye of the patient. Is it visible here? If we notice here in the upper quadrant, there is one small dot, that is microaneurysm, and one small dot here. Might not be visible there, but it is visible on my. It is visible there because I know. Here it is. I didn't encircle. There is slightly redness. One dot is here. So this is the way we find that it is mild NPDR, and this much spot which is not creating any problem or which is not visible to us, if it is here on the macula or the fovea, patient will feel the significant difference. This, if we find it here, this is alarming that we need to prevent it to come on the macula. Moderate, these are the hard exudates, and here is the hemorrhage. This is flame shaped hemorrhage which we see in hypertensive retinopathy. Is it visible there? In severe, as I already told, more than 20 intraretinal hemorrhage in each of the 4 quadrants, definite venous bleeding in 2 or more quadrants, prominent IRMA, that is intraretinal microvascular abnormalities, in 1 or more quadrant. But there is no signs of proliferative retinopathy. What sign? Let's come on it. This is the venous changes which we find, and hemorrhages are in all the quadrants. Now coming to PDR, that is proliferative diabetic retinopathy, presence of vitreous or pre-retinal hemorrhage. Vitreous hemorrhage, if in diabetes, it is sign of proliferative diabetic retinopathy and it can cause sudden defective vision. Presence of new vessels, location of new vessels on or near the optic disc or anywhere in the retina. If it is visible, we can see multiple loops of the vessels on the optic disc. This is the neovascularization on the disc. When there is neovascularization on the disc, it means that there is ischemia all over the retina. We need to control that ischemia to revert this neovascularization. So coming to the diabetic macular edema, before coming to it, I would like to explain one thing. So even if there is PDR, that is proliferative diabetic retinopathy, patient may not have defective vision. Whatever changes are there, neovascularization is there, pre-retinal hemorrhage is there, or the neovascularization on the disc, whatever it is, if no vitreous hemorrhage and PDR is there, patient may not complain of defective vision if the macula is not involved. Even in proliferative diabetic retinopathy, macula is not involved. Many a times patient come to us, come for the cataract surgery, their whole retina is gone, macula is fine, there is no cataract. So even if patient is not complaining of defective vision, that doesn't mean that patient is not having diabetic retinopathy. They can have at their extreme level as well. So the diabetic macular edema is the leading cause of legal blindness in diabetics. The diabetic macular edema can present at any stage, as I told, but is more common in patients with the PDR. Diabetic macular edema may be asymptomatic at first. As the edema moves to the fovea, the center of the macula, the patient complains of the blurry vision. Coming to the CSME, the clinically significant macular edema, because this is the thing which we need during the diagnosis and the treatment of the patients. In this, there may be edema at the edge of the macula, but that will not deteriorate the vision. So, the treatment approach differs. Thickening of the retina at or within the 500 microns of the center of the macula, hard exudates at or within 500 microns of the center of the macula, if associated with thickening of adjacent retina, means if there is hard exudate, there was edema before, when the edema subsided, hard exudates precipitated, and area of the retinal thickening 1 disc area or more within 1 disc diameter of the center of the macula. This is the OCT, that is optical coherence tomography, the examination which we do routinely in our general practice, in which we get the section of the retina, and here the fovea, this is cystic edema, and the dip which we find here, this is the fovea where the best vision is there. If the fovea is elevated, even the slight elevation, that will cause the deterioration of vision. The microaneurysm which I was discussing, if the microaneurysm is near or at the fovea, the patient will have significant vision loss. And this is a kind of main investigation which we do while treating the diabetic macular edema. So 90% of the diabetic eye disease can be prevented simply by proper regular examination, treatment and by controlling blood sugar. Primary prevention is none other than strict glycemic control and blood pressure control. Secondary prevention is annual eye examination, which we only can promote. We are really trying hard to create the awareness among patients. And tertiary prevention, I hope that no one comes to it, is retinal laser photocoagulation or vitrectomy or the anti-VEGF injections. So laser photocoagulation, why it is done, like whenever there is diabetic retinopathy, there is ischemia, and that ischemic part releases vascular endothelial growth factor, which leads to neovascularization. So in laser, we burn that ischemic part so that VEGF load is decreased, and that may not lead to neovascularization, which further causes the fibrovascular band and the tractional retinal detachment. The next is intravitreal anti-VEGF injection. For last decade, this is a magic to the eye diabetic, not even diabetic, in the ARMD cases also. This immediately reduces, within 24 hours, it reduces the VEGF load in the eye, and it works on the new vessels as well as on the edematous part. Though it is not permanent, this VEGF is in the vitreous. We give intravitreal injection of VEGFs, anti-VEGFs, and it washes away within 1 month. So what I personally tell to the patient that anti-VEGF is not the permanent treatment. बहुत बारी पेशेंट्स आते हैं कि मैंने लगवाया था इंजेक्शन, 4 महीने पहले लगवाया था, फिर से बढ़ गया, तो मैं यही बोलती हूँ कि मैंने इंजेक्शन लगाया, वो मैंने बस पोछा मारा है, टैप आप ही को बंद करनी पड़ेगी, जो पानी गिर रहा है, जो शुगर कंट्रोल है वो आप ही को करना पड़ेगा. सो more time which I take to inject, rather I take more time in counseling of the patient that please control your diabetes, because that is the main treatment instead of giving injections or instead of going for the lasers. But yeah, till date laser is not the substitute of anti-VEGF. Anti-VEGF is a temporary treatment, and whatever the ischemic part which is dead, we have to burn it, we have to stop it. Anti-VEGF will only reduce the, at present whatever the VEGF is there, that will control that only, but whatever continuous release of VEGF is there, that can be controlled only by damaging or destroying that ischemic part or infarcted part. And this vitrectomy is the last resort when there is already tractional retinal detachment. In vitreous hemorrhage, if it is not resolving, what I said that vitreous hemorrhage comes to be very alarming to the patient because sudden defective vision, only hand movement remains within few hours. So if the vitreous hemorrhage is not resolving within 2 months, then we may need for the vitrectomy, and of course in the tractional retinal detachment we go for vitrectomy. पहले ही बता दे रही हूँ. Laser treatment is to seal the leaking blood vessels, and it is to reduce the retinal oxygen demand there, and surgical removal of blood from the eye. The first one which I want to tell, laser therapy to seal the leaking blood vessel. This is the focal laser which is done on the macula. Very low energy is used, and whatever the macro and micro aneurysm are there which are barely visible, we burn on we give the laser only on that, only the microorganism get burned, and slowly it decreases the edema. Like anti-VEGF works immediately, but that edema subsides very slowly but permanently. Use of antivascular endothelial growth factor antibodies have been shown to be useful in treatment of diabetic retinopathy. Anti-VEGF antibody treatment appears to be useful for both macular edema and PDR, proliferative retinopathy. It works both on edema as well as the new vessels. Studies to determine the exact role of anti-VEGF in relation to laser treatment in specific situation are still undergoing. Now coming to the newer modalities which I came to know when I was going through all these. PKC 412, newly diagnosed FLT3 mutated acute myeloid leukemia. The high dose causes significant decrease in thickening in the region of greatest thickening in the fovea. I don't have many studies related to it, I have not heard in my conferences as well, but I came to know. So these are the medicines which you people are more aware of, so I was interested in including it. So what are the risk factors? Till now what we know, the duration of diabetes, which is important, sugar control, which is important, but there are few systemic factors which are there which is to be taken in control, like hypertension. Once the blood capillaries pressure will be high, even if it is small microaneurysm, the pressure may cause the hemorrhage there. Then hyperlipidemia is having direct association with the deteriorating diabetic retinopathy. There are studies which says that hard exudates or the cholesterol deposit can be removed with the but it is not proven that with the anti-lipid medications. There are few retinal surgeons who do give anti-lipid agents if there is hard exudates and there is it is going towards the fovea, then there is no harm in giving. Anemia is having direct association. If the patient is anemia, the diabetic retinopathy deteriorates very fast. And one latest thing is hyperhomocystinemia. It causes diabetic retinopathy deterioration as well as the venous occlusion. The vein occlusion in the retina is very common, and this is one of the common cause apart from the hypertension. Separate from all these is a rare autoimmune disease, that is type 1.5 diabetes, which is untreatable through dietary or lifestyle changes like increased exercise. So it straddles between type 1 and type 2 diabetes with elements of both. So sir, आप कुछ कह रहे थे? जी
1.5 diabetes.
हाँ जी, I came to know about 1.5 diabetes and diabetes type 7 also, पर वो ज़्यादा हो जाता है. So patient tend to go to insulin much quicker than patient with a type 2. And diabetic retinopathy prevalence, there are many studies related to type 1.5, and the prevalence is 26.4 in these patients, lower than that in the type 1 and type 2. Diabetes duration and diabetic nephropathy are the independent risk factor. Whatever patient come with a diabetic retinopathy to us, we do send the patient to any nephrologist or their general physician. We ask the patient to go for the renal profile also. In patient without diabetic nephropathy with diabetes duration of at least 10.5 years, type 1 diabetes mellitus and type 1.5 patients had higher risk incidence of diabetic retinopathy than type 2. Type 1.5 and type 1 is at higher risk than type 2 always. Insulin use, whenever patient is there with the diabetes, we say that go on insulin, patients always avoid that. Even if we are planning for the cataract surgery, then they go and they get the insulin, they get operated, and later on the diabetes shoots when they get operated. Insulin use increases macular edema risk, whereas oral anti-diabetic intake were probably not associated with diabetic macular incidence. So we need to keep an eye that if the patient is on insulin, many a times patient don't take the opinion of doctor, they monitor it themselves. so whether they are taking the right dose or not. The use of thiazolinidione, especially pioglitazones, are known to deteriorate the diabetic macular edema. If the patient is having diabetic macular edema, we prefer to stop pioglitazone and switch to any other medication, anti-diabetic medications. So, regular diabetic retinopathy screening is an independent protective factor. Alone, we can do so little, and together we can do so much. Thank you. Sir, I hope I didn't miss anything. Please help.
Okay. पर तालियां जोर से बजनी चाहिए। कई बार होता है कि डायबिटीज़ पता ही नहीं है, जब पता चली ऑलरेडी डायबिटिक आ गई है। तो मेन कॉज इज इस्कीमिया डायबिटीज़ प्लस डायबिटिक है तो हाइपरटेंशन भी साथ साथ चली आती है। दोनों भाई बहन हैं दोनों। तो मेन प्रॉब्लम इज इस्कीमिया है तो खाना बंद हो गया तो कहीं ना कहीं से पानी लेना ही है आपको, तो न्यू वेसल्स आना शुरू हो जाते हैं। सो ए जनरल प्रैक्टिशनर कैन ऑल्सो डायग्नोज इनिशियल स्टेजेस ऑफ डायबिटीज़ रेटिनोपैथी कि आप लोग क्या करना है, फेनाइलेफ्रिन ड्रोसिन को डायलेट करने के लिए एक ड्रॉप डाला, पिपिल आप 15-20 मिनट में डायलेट हो गया। जस्ट हैव अ लुक इनटू द फंडस, आपने ऑप्टिकली से देखी, टास्क पेशेंट लुक इनटू द लाइट, आपको ये दो चीज़ें दिख गई, बिकॉज यहीं से डायबिटिक रेटिनोपैथी शुरू होती है और विजन थ्रेटनिंग भी यहीं से आती है। तो पहली रिस्पॉन्सिबिलिटी आपकी है, बिकॉज पेशेंट हमारे पास आता है ऑलरेडी ब्लाइंड हो चुका होता है। वंस द रेटिनोपैथी स्टार्ट्स हिटिंग द मैकुला, न्यू वेसल्स आना शुरू होगा, बिकॉज जब नहीं मिली ऑक्सीजन उनको इस्कीमिया से तो न्यू वेसल्स आना शुरू हो जाते हैं। न्यू वेसल्स की लेयर्स भी वेसल्स की बड़ी अच्छी नहीं होती हैं, ब्रेक कर जाती हैं, हेमरेज आ जाती है, क्लॉट्स आना शुरू हो जाते हैं। तो जिसको हम लोग कहते हैं कि एक्सुलेट आना शुरू हो गए, नो प्रोलिफरेट करना शुरू हो गया, बिकॉज टू कंपनसेट द इस्कीमिया प्रोलिफरेशन कम्स। तो जब तक नॉन प्रोलिफरेटिव रेटिनोपैथी है विजन थ्रेटनिंग नहीं होगी, लेकिन इट कैन टर्न इनटू प्रोलिफरेटिव जो कृति यूज़ कर रही थी एनी टाइम ड्यूरिंग द ट्रीटमेंट। लॉन्गर द ड्यूरेशन, मोर चांसेस ऑफ रेटिनोपैथी अफेक्टिंग द विजनल लेयर। पहला काम आपका है, हमारा नहीं है, बिकॉज हमारे पास तो जब आता ऑलरेडी हो चुका होता है। एंड बताया तो बड़े आराम से 10-12 चीज़ें बताई हैं डॉक्टर मित्तल ने, लेकिन बहुत ज़्यादा काम नहीं करती हैं। एक बार उसमें कुएं में गिर गए तो आपको कुछ ना कुछ विजन लॉस हो जाएगी। व्हाट वी डू इज वी ट्राई टू सेव एज मच यूजफुल विजन एज पॉसिबल। मेरे बहुत से मित्र लोग यहाँ बैठे हैं जो मेरे पास आते रहते हैं और नॉट मिलते हैं, बट मेन काम हमारा क्या होता है, डायबिटिक आजकल इतनी कॉमन हो गई है, नॉट बिकॉज कॉमन हो गई, हमारा लाइफस्टाइल खराब हो गया है। आपको यहाँ से चौराहे तक भी जाना है तो यू डोंट वॉक, आप गाड़ी निकालोगे, स्कूटर निकालोगे, मोटरसाइकिल निकालोगे, वो बंद हो गया है, वन एक्सरसाइज का टाइम ही नहीं है। तो आई थिंक हमारा लाइफस्टाइल चेंज हो गया है, तो डायबिटीज़ हावी हो ही जाएगी, बिकॉज बर्नआउट नहीं हो रहा है। तो पहला काम आपका है। सो व्हाट यू डू इज़ एनी डायबिटीज़ विच इज़ एटलीस्ट 2-3 years ओल्ड, आपके पास तभी आएगा वो। तो एक हम लोगों से नाम लीजिए, ड्रोसिन फिनाइलेफ्रिन एक ड्रॉप डाला, 15 मिनट में डायलेट होता है, 15-20 मिनट में लोग इंटू दी फंडस नहीं समझ आती है तो भेज दीजिए, बट भेजिए तब जब शुरू हो रहा है, बाद में बहुत ज़्यादा करते। बाद में क्या हुआ, एक्सुलेट्स आ गए, हेमरेजेस आ गए, ब्लीडिंग हो गई, ट्रैक्शन, जब फाइब्रोसिस होगा ब्लड वेसल्स का पुल ऑफ द रेटिना, आ तो वहीं से रहे हैं ना, तो ट्रैक्शन होगा, ट्रैक्शन में से रेटिना डिटैच हो जाएगी। तो विट्रियस बैंड का डिटैचमेंट ठीक करें, विजन कभी यूजफुल। बहुत से लोग आपने देखा अपने परिवार में होंगे जिनकी विजन काफ़ी ख़राब हो चुकी है। सो फर्स्ट स्टेप इज़ यू ओनली। इसलिए आई वॉज वेरी हैप्पी दैट ये वाला टॉपिक आप लोगों ने रखा, बिकॉज हम लोग सब आपस में काम किया है पेशेंट को बचाना है, बचाओ। उसी समय हाइपरटेंसिव ब्लाइंड नहीं करते, हाइपरटेंसिव ब्लीड कर देगी आपको, आँख में ब्लीडिंग हो जाएगी, उसकी ट्रीटमेंट बहुत मुश्किल नहीं है। डायबिटिक रेटिनोपैथी साथ में होती ही है, उसको बचाना बहुत ज़रूरी है। सो ऑल फिजिशियंस हु आर ट्रीटिंग डायबिटीज़ फंडस इनिशियली आप लोगों को देखना है, बहुत मुश्किल नहीं है देखना। अनडायलेटेड पीपल भी मुश्किल होगा, तो हमको भी नहीं दिखता, मेरे को इसे भी नहीं दिखता है। सो पुट ए ड्रॉप ऑफ ड्रोसिन, कोई कॉन्ट्राइंडिकेशन नहीं है, वेरी चीप ड्रग, एक ड्रॉप डाल के 20 मिनट बाद उठा दीजिए, जिसका आपको दिखी जाएगी। एज लॉन्ग एज द पेशेंट लुक स्ट्रेट, आस्क हिम टू लुक इनटू द लाइट, दोनों चीज़ें आपको दिख जाएगी, ऑप्टिक नर्व दिख जाएगी, मैकुला दिख जाएगी, और कुछ नहीं करना है। दिखता बड़े आराम से है, ब्लड वेसल्स नॉर्मल नहीं है, उस ए वेस्कुलर एरिया है, मैकुलर एरिया, वहाँ आपको ब्लड वेसल्स दिख रहे हैं, वहाँ आपको ब्लीडिंग दिख रही है, प्रोलिफरेट कर रहा है, बंच ऑफ ब्लड वेसल दिख रहे हैं। तो भाई मेरे टाइम में तो फोटोकोगुलेशन लेज़र थी ही नहीं। वी हैव माय शुक्र की बड़ी सी मशीन थी, उसमें बंद करते थे। डैमेज टू मैकुला वाज मोर बाय द कोगुलेशन रादर देन द डिजीज इटसेल्फ, बर्न आउट करता था। अब इतनी अच्छी अच्छी मशीनें आ गई हैं, लेज़र आ गई है, किस लेयर में आपको करना है, क्या करना है, सिलेक्टिव एरिया कर सकते हैं। दे आर एक्सपर्ट्स फॉर दिस ओनली, वो आर डूइंग ओनली डायबिटिक रेटिनोपैथी ट्रीटमेंट। उनके पास भेजिए, हमारे शहर में भी हैं 3-4 हैं जो बड़ा अच्छा काम कर रहे हैं। और एक आज तो स्पेशलाइज हो गया मेडिसिन काफ़ी, तो डोंट हेजिटेट। आपका पेशेंट हमारे पास भेजने से यू डोंट लूज एनीथिंग, पेशेंट नहीं जाएगा कहीं, बिकॉज हम लोगों को डायबिटीज ट्रीट करना नहीं आती है। वेरी फ्रैंक, हम वापस आपके पास ही भेजेंगे। आजकल इसलिए नहीं रेफर करते कि मेरा पेशेंट चला न जाए, कहाँ जाएगा भैया, वही रहेगा। तो प्लीज़ मेक श्योर दैट इफ डायबिटीज इज वन ऑफ योर गोल। कई बार इनिशियल स्टेज में पेशेंट जब आता है, विजन लॉस नहीं होती है, वो ऐसे डायबिटीज चली आ रही है, मीठा कम कर दिया, चलना शुरू कर दिया, डॉक्टर को भी नहीं दिखाता है वो। तो जब दिखाया उसने, तब आपने बोला ये डायबिटीज, ये मेटाबॉलिज्म ठीक हो जाएगा, ठीक हो गया, ब्लड ठीक हो गया, कुछ नहीं करना है। बट ए डॉर्मेंट डायबिटीज ओवर देयर विच इज प्रोड्यूस इस्कीमिया, इस्कीमिया से वेजिटेटिव ग्रोथ आएगी, तब एंटीबायोटिक ट्रीटमेंट ज़्यादा काम नहीं करती है, लेकिन डैमेज तो हो गया ना। ओके, एंड द साइट इज गॉन, एवरीथिंग इज गॉन।
सर ये बड़ा अभी स्लाइड मैंने देखा कि टाइप 1 डायबिटीज में 99% ऑफ द पेशेंट्स लैंड अप इन रेटिनोपैथी। तो उसमें क्या
रेटिनोपैथी, तो हम जो कह रहे हैं कि लैंड्स अप इन रेटिनोपैथी, वी आर मोर कंसर्न विद साइट थ्रेटनिंग रेटिनोपैथी। सारी बॉडी में ही न्यू वेसल्स ग्रो हो रहे हैं डायबिटीज में, तो आँख में नहीं ग्रो होंगे। आँख में यू कैन सी द ब्लड वेसल्स, बॉडी में यू कैन नॉट सी देम। This is the only living area where you can see live blood vessels. इसलिए
except for glycemic control or dietary or whatever in type 1
और कुछ नहीं कर सकते।
क्या और
Sir,
अगर फंडस में changes आ गए,
hypertensive and this nephropathy, everything, not just diabetes,
That is
anemia, that all helps.
बहुत चीजें हैं।
duration also happens because type 1 diabetes becomes for so long time.
लंबा चलता है, यंग एज में हो जा रही है।
So that is the more duration you have, the more time.
लाइफ स्पैन इज इंक्रीज नाउ। 40 साल का डायबिटीज हुई, पहले 50-60 में मर जाता था।
early diagnosis probably
Our parents, grandparents did not live more than 70-75 years old. 60 में रिटायर हो जाता, 58 में, फिर 60 में, 15-20 साल देने उससे पहले ही बाबू जी चले जाते थे। तो अब लाइफ स्टाइल इस लॉन्ग है, आपके सामने खड़ा है, कुछ नहीं है।
So one more thing which we have noticed practically, that when patients are diagnosed as diabetes, they are having very high blood sugar or very high HbA1c, maybe 9, 10, 11, 12. So when they come to 8 or 9, they are okay with it. It is quite controlled. Even one of my friend, she is diagnosed as liver disease, and she's of my age. Liver disease as well as diabetes. And I asked about her HbA1c. She says that it's fine now. How much? 9. It was 12. And what I explained to them, you are even if you are diabetic, you have to bring your HbA1c in under non-diabetic stage, especially if you are started developing diabetic retinopathy. That HbA1c and average blood sugar, even if the patient is not having diabetic retinopathy, probably I am here to learn, not to present. So what the one thing which we learned is that if the patient is having diabetes more than 8 years, 10 years, and there is no creatinine rise, I personally advise them to go for the 24 hours urine protein for the pre-level of the nephropathy, because we know that nephropathy will cause the diabetic retinopathy later on. So if any other thing which you all can suggest to control nephropathy, to control hypertension, which we can advise to the patients.
क्या करना चाहिए? जैसे डॉक्टर ने कहा ऑप्थेल्मोस्कोपी फिजिशियन को भी करना चाहिए, प्रॉपर समय में ये पेशेंट का भलाई हो सके जो है, क्योंकि जो होता नहीं है, सही बात है, इन लोगों के पास पेशेंट जब आते हैं सब ऑप्थेल्मोलॉजिस्ट क्या करेंगे, इसीलिए एक अवेयरनेस दृष्टिकोण से वही डॉक्टर्स एंड फॉर हमारे द्वारा पेशेंट को भी जाएगा। कुछ बोलिए आप, हम लोग को पढ़ाइए सर थोड़ा सा।
ड्यूरेशन ऑफ डायबिटीज इज मोर इम्पोर्टेंट। इन वेल कंट्रोल डायबिटीज में रेटिनोपैथी होती है।
यस,
बिकॉज अभी जो रेशन स्कीम में तो चल ही रहा है ना।
Our main frustrating experience is patient doesn't follow. सबका ये problem है. I have got ophthalmoscope since 1988. I had been using it, लेकिन अब कम होता है. फ्रस्ट्रेट हो जाता है आदमी. करते करते कहो उसको आ रहे हैं नहीं है कुछ भी, मतलब this is the main problem. Anyway, for the diabetes, once you ask them, they don't follow you. HbA1c is, to the patient who come to me, their HbA1c is around 14, 15. Usually this is 14, 15. I am coming from long distance, this is this and that. Coming to me after 6 months or 7 months. Anyway, initial treatment of diabetes, I advise them, they do follow, but most often they don't return back. Anyway, I start with anti-diabetics and all the these जो मतलब ये इनके precautions होते हैं, जो भी ये dietary restrictions और जो भी हैं, I ask them. और now recently there has been lot of changes in diabetic treatment, sulfonylureas and other acarbose inhibitors and thiaglipizone derivatives. It depends. Upgrading of our doctors is very necessary. To whom which drug suits. Patient comes to me most often with 500, more than 550 blood sugar. It is not necessary I go for insulin. I control it within 7 or 10 days with my latest up-to-date knowledge. Which drug has to be given which patient. If HbA1c is more than 40, mostly they come around 12, 14, 15 HbA1c. It is getting controlled within 1 month, 2 months. But once I control, they go and leave. छूट गए दवाई 3 महीना छूट गया, 2 महीना छूट गया. This is very frustrating experience. Ophthalmoscopy के लिए I purchased it in 1988. I had been using ophthalmoscope. I have been doing it. But this is frustrating experience. You go for that, they leave your treatment, they forget about it. I ask them, you go there, they tell, oh, I am going there. They don't go there. Once we, apart from physicians, in every field of our medical fraternity, everybody needs upgradation about diabetic treatment and diabetic awareness. Even if they don't treat diabetes, they should be upgrading their diabetic knowledge because a lot has changed and it is very simple. And what changes has been made, later they say, oh, this is not, I am not concerned with this. It is not okay.
All the clinicians should know about it.
Every clinician.
Maybe surgeons, chest
Everybody has become physician. I remember few weeks back, I went to sir. He said me one thing. He said me, you are a clinician. I felt proud of me. I am a clinician. I am not a physician. Because we have got our clinical sense. अब डॉक्टर करता है अल्ट्रासाउंड में चाहिए रिपोर्ट आया, we don't do that. हमने कहा अल्ट्रासाउंड में ये है तो वो है, वो निकलेगा, वो निकलना है. हम लोग के टीचर्स स्टेथो में लगा हुआ है, listen, this is correct. तो I once listen, this is correct means correct. ये है मतलब knowledge, style of functioning and knowledge has changed a lot. But we all should remain clinicians. Our clinical sense should be improving. One of my teachers, Dr. V.R. Sinha, was a first year at Kodi Patna. I remember once he said, in our field nobody is static. Either he is improving or he is deteriorating. I still remember, he said very correctly, either he is improving or he is deteriorating.
सब दिन रहेगा एक समान.
बिल्कुल बिल्कुल ये फैक्टर है. डायबिटीज में सबको अवेयरनेस जरूरी है और अपना नॉलेज ये कह देने से पीछा नहीं छूटेगा क्योंकि डायबिटीज सबके फील्ड का है, सिर्फ फिजिशियन का नहीं है. नहीं है, बिल्कुल सबको फिजिशियन का बिल्कुल नहीं है. तो ये चीज़ है कि सबको, सर्जन को, पीडियाट्रिशियन को, सबको. और जैसा कारण डायबिटीज बहुत अर्ली स्टेज में हो जा रहा है, लोग छोड़ देते हैं और सबका वो है कि सबसे फ्रस्ट्रेटिंग एक्सपीरियंस ये, हम इतना मेहनत करके करते हैं, छोड़ देता है ट्रीटमेंट। एनीवे, थैंक यू ऑल।
I am having two questions. What is a crack in the retina and how it is treated?
Crack.
Crack.
Break word I have heard and read, ma'am. Break in the retina is a
break in
yeah, retinal hole. Retinal hole is there, and retinal hole can be in the early age as well as in the late age. And
In a diabetic patient.
if it is diabetic patient, there are few of the reasons. First one is tractional retinal detachment. In tractional retinal detachment, whatever the new abnormal vessels are there, slowly they get fibrosed. That is attached to the retina, and slowly when the fibrosis is there, it contracts, it pulls the retina, and when the pull is too much increased, that causes the tractional retinal detachment and the hole there. And whatever the vitreous liquefied is there, that liquefied vitreous will go beneath the retina, and that will cause retinal detachment. So it is combined retinal detachment. That is the worst retinal detachment to be operated. Tractional retinal detachment plus regmatogenous means the fluid is behind.
What is buckling treatment?
Yeah, I'll come to it, ma'am.
Yeah.
Then what, apart from the diabetic retinopathy, if we can develop the crack or the break in the retina, that we can get in the early age also, especially in the myopic patient.
Yeah.
So if we will get in a myopic patient in early age, the vitreous is gel and it is not very much liquefied, that break may remain there, or maybe that liquefied vitreous go into that break, and it can cause the retinal detachment, that liquefied vitreous. So in this case, the surgery is the only thing, the only treatment is remaining. So that is the reason myopia is one of the main problem, refractive error, in which we want the regular eye checkup, dilated eye fundus examination. Why? Because in myopia the eyeball size is increased, and usually when the eyeball size is increased, in the periphery it is getting stretched, and there thinning is there, which is called lattice, and when the thinning progresses it causes break, and when liquefied vitreous goes, it goes inside. Buckling, what you said, usually it is done in tractional retinal detachment as well as which I was talking about was myopia. Like this is the eyeball, here there is break, this is the cornea. If the break is there, what we can do, either we can seal the break, like in the case early there is break and there is no fluid behind the retina, no detachment, then we laser it. But if it is already detachment is done, we take out the fluid, we buckle the eye, we bring this closer, so the stretch which was creating the hole, we release that break, we release that stretch which is causing the hole, and that is loosening happens, and that buckle thing holds the retina at this place.
What is the follow-up?
Follow-up of this case, ma'am,
Yeah.
which one? Like
After
buckling.
buckling, what is the follow-up?
That depends, ma'am, why the buckling was done. Like
Myopia and diabetes.
I'll tell both the things.
Actually controlled diabetes.
Buckling, ma'am, buckling is not done for myopia or for diabetes.
Yeah.
Oh, it is done for the retinal detachment.
Yeah.
If it is the retinal detachment in myopia and it is well attached, once in a year, if the patient is young, once in a year is fine if it is well attached, because whenever the buckling is done, proper lasering is also done, so whatever the thin part is there, that is strengthened. Once we laser it, there is fibrosis and adhesion of the retina and choroid, and it is quite tight. So the chances of the retinal detachment is less, and the progression is also very less. So we do it once a year. In diabetic retinopathy, buckling is done, it means that traction was there. And traction was there, and that we are releasing the traction. So that depends on that where was the traction. If the traction was on nasal side, it is usually not in periphery. Diabetic retinopathy, the worst part is that it affects the posterior pole. So if it is on nasal part, we can delay it to 3 months or 6 months. That absolutely depends on the patient to patient. If it is threatening the macula, then the close follow-up, rather more systemic control is important. And how much the patient's vision is there, and not just buckling. If the tractional retinal detachment because of the diabetic retinopathy is there, then one more step, vitrectomy is done. All the vitreous is taken out. So when the vitreous is taken out, no traction remains on it. But the fibrovascular band remains there. When it continues to contract even after the tractional detachment is removed, it may cause deterioration of the vision. So if it is near to macula, we go for the close follow-up. We again try to seal it with the laser. If doesn't happen, then again we have to go for the vitrectomy. Then the advanced surgery comes, we do the retinotomy, that is hole in the retina. Which the vision part, we leave the macula part. Apart from it, we make a hole so that the traction remains, only the fovea or only the macula remains and the central vision remains. So what is not a sign of diabetic eye disease? So floaters can be there. Floaters can be there. Why? Because floaters is very common in youngsters with the myopia. Because in myopia, मैं सारा explain भी करती जा रही हूँ. Because in floaters what happens when the vitreous gets liquefied, we face floaters. In myopia we can get floaters. Even I am having -1.5 and I am having floaters both the eyes. And in old age, rather in 50-60, vitreous automatically gets liquefied and floaters is very common. नहीं सर, मैंने बोला old age rather 50-60. आपने वो correlate कर दिया सर. So this floaters usually what we have seen that patients do come if the floaters is significant. This is because of the posterior vitreous detachment. Vitreous is attached to few of the places. I was about to come on this topic, but I thought that it will go too deep. It is attached to the disc, it is attached to the periphery and the vessel margins. When we get the posterior vitreous detachment with the age, progressing age, be it be young, then there will be floaters in front of eyes. If any of the person is getting sudden onset floaters, whenever the posterior vitreous detachment happens, many a times it detaches the retina as well. What you were talking about is break. Especially in the myopics, what happens that when PVD, that is posterior vitreous detachment happens, it can cause retinal break. So any case of acute floater should be examined, dilate fundus examination for any retinal break. In diabetes, the floaters is very common because of vitreous hemorrhage. And vitreous hemorrhage is because of...
answer is the D, okay?
Yeah, answer is the D. Little getting late.
So, Dr. Ashok,
Not a sign of diabetic retinopathy.
I request you to just raise your hand and Pratibha ma'am will select. Not a sign of diabetic retinopathy.
अब क्या बोलूं? मैं नहीं बता पाऊंगी.
Just raise your hand.
Is it okay?
Actually, disc edema is also a sign of diabetic retinopathy. It is called diabetic papillopathy, acute rise of diabetes.
So all is the answer.
Yeah, all is the answer.
So, ma'am has given the right answer.
Drug with no adverse effect on macular edema. Insulin, pioglitazone, metformin, none. नहीं मैम मैंने बोला था पायोग्लिटाजोन does cause deterioration in the vision. Metformin. किसने बताया मुझे नहीं पता.
Dr. Chakrapani?
Diabetic capital of world.
India.
हम भारत सब में आ गए हैं. Diabetes retinopathy can be prevented by controlling HbA1c, controlling lipid, improving hemoglobin, improving nephropathy. That will control all. फिर से थैंक यू पे आ जाती हूँ. थैंक यू एवरीवन.
बंदिशें लगानी चाहिए। उम्र ने मेरे बढ़ते कदमों पर तमाम तरह की बंदिशें लगानी चाहिए, पर मेरी जिद के आगे उसकी एक न चली। मैं आगे बढ़ती हुई चांद व सितारों तक जा पहुंची। चांद ने कहा तुम वापस धरा पे जाओ। चांद ने कहा तुम वापस धरा पे जाओ। धरा पे तुम्हारे बहुत सारे दोस्त हैं, वे तुम्हें बहुत चाहते हैं और इसीलिए वे तुम्हारा हमसफर बनकर और तुम्हारे दोनों हाथ थामकर जीवन की कठिन डगर पर तुम्हारे संग चलना चाहते हैं।